अच्छा ಇவ்வளೋ ಕಷ್ಟಪಟ್ಟದಲ್ಲ ಎಷ್ಟು ಒಂದು 3 ಬೇರೆ ಗಮನಿಸೋಣ
ಗುಡಿಂಗ್ ಕೊಟ್ಟಿದ್ದಾನೆ ಗುಡಿಂಗ್ ಸಹ ಕೊಟ್ಟಿದ್ದಾನೆ
ನಾನು எங்கள் டிபார்ட்மெண்ட் people colleagues தான். Hi, am I audible to you? Dear students, am I audible to you? Okay, good evening all of you. Good evening. This is the INICET session that we are going to start right now. I'd like you to focus on the session in such a way that you try to take the most important pointers home. You should be able to crack these MCQs along with me. Now, these questions have been framed in such a way, they are taking inspiration from that of the previous year questions, and I'll be putting forward what kind of things can actually be asked in the future for you, so that it will be easier for you to combine both the logic and bring out a good answer. So that is where we are going to start with. And please remember, at any point of time, if you'd like to ask me, you can ask me questions. Just give me a moment. The iPad is, yeah, it's mirroring. It's mirroring. It's mirroring. Yeah.
Then it clicks live stream and then chat stream.
Yeah, shall I start? The chats, I do not know how to start with. This is not actually working properly.
Chat, I think because of the internet. You use your phone only. That is better for today.
Okay, okay, okay. Yeah. Am I live? Yes. Am I audible, dear students? Hi, sorry for the technical issues here. Am I audible to you? Excellent. So, what is the answer? We get the first answer here. This is given by Akshay Vijayakshan. Akshay Vijayakshan, thank you. This is the right answer. The right answer is APO B48. The problem here is people actually confuse APO B100 with that of APO B48. Now, what are the most important questions raised from this topic? What are the most important questions raised from this particular topic? See, when APO B100 has to become APO B48, the concept is called as mRNA editing. mRNA editing. Now, you will be having a simple thought process in genetics trying to be linked with that of lipid metabolism. What is that particular difference? See, in case of lipid metabolism, you focus on APO B100 for that of LDL and APO B48 in case of chylomicrons. See, chylomicrons are the carriers of the lipoprotein, I mean the lipid called as triacylglycerol. Point number 1, chylomicrons carry triacylglycerol. Point number 1. Now, what about VLDL? VLDL also carry triacylglycerol. Point number 2. Now, what is the difference? Chylomicrons will carry the triacylglycerol from the exogenous sources, which is the diet, while VLDL will be carrying it in case of endogenous nature, which is the liver synthesized VLDL or liver synthesized triacylglycerol. Now, how does the intestinal cell have this difference of having B48 rather than going for B100. The concept is mRNA editing. You will be having an enzyme called as deaminase. You will be able to have, can anybody tell me what deaminase it is? Excellent, human nature, that is correct. Can you tell me what deaminase are we dealing with now? Anybody for that matter, what deaminase are we dealing with? Excellent, cytidine deaminase. In the intestinal epithelial cells, you will be having the enzyme cytidine deaminase being active. Now, what does a cytidine deamination do? If, for example, you have a gene, a codon called as CAG, if this C is going for deamination, that becomes U. Now, what is UAG codon? What is this UAG codon? Excellent, Stardust. You will be able to have this particular CAG or CAA being converted into UAG or UAA. Now imagine this. I'll be using a different slide here. Now in case of the codon, you have CAA. If it is knocked off, that CAA becomes UAA, which is stop codon. Now when that stop codon comes into existence, the whole of the process of transcription and translation will stop at this level, which is 48% of the ApoB100. That will lead to the concept of formation of B48. Now this B48 is the apolipoprotein present in a chylomicron, which is important for transporting the exogenous triacylglycerol. So for ApoB48 to come into picture and not ApoB100, you have to have the CAA cytidine deaminase into action. Now this is a simple topic to start with. Now look at this part. We have exogenous, we have endogenous triacylglycerol. The dietary triglycerides, dietary cholesterol will come into picture. You will be able to have the chylomicrons incorporating the triglycerides and cholesterol. Lipoprotein lipase will be able to use the difference, because of which fatty acids and triacylglycerol can be divided. Now they will be traveling into the liver, and endogenous triacylglycerol is present in the VLDL. They'll be again traveling from the liver to the different parts of the body. Now try to answer this question. Try to answer this question. Okay, a 45-year-old male presents with. Now, this is how the questions can actually be difficult for both university exams in terms of CBME syllabus and also in case of INICET or that of NEET PG exams, where they will try to link the recall based data into a clinical concept, and you have to tell us what exactly can go wrong. Now, we will be discussing the dyslipidemias. This is a classical case of dyslipidemia. This is a classical case of dyslipidemia, and I would like you to answer this question after reading the theory part of it. Now, what are the important points to notice? The age of the patient is 45-year-old and he is a male. He presents with complaints of severe abdominal pain radiating to the back. Whenever you have abdominal pain radiating to the back, what do you understand? Excellent, Stardust. That's a very good answer. I'm just asking a simple question. When you have severe abdominal pain radiating to the back, what do you understand from that? See, you are speaking about pancreatitis. You can actually say pancreatitis because you know this condition is hyperchylomicronemia. But what I would want you to understand is whenever there is an abdominal pain radiating to the back, think of it as a retroperitoneal origin. Point number 1. Now the pain has retroperitoneal origin. I'll try to help you crack this question in a stepwise fashion. It's obvious you can actually get the right answer, but these questions have been trimmed to be very simple for you. I'll just show you how it can become more and more difficult at the levels where I can make a small twist or tweak in the question. Now, whenever the pain is in the abdominal area and it is going to the back, you think of retroperitoneal origin. Now look at this. Here, the patient is having increasing fatigue over the past few months and noticeable weight gain of approximately 5 kgs. So the patient is having weight gain and there is no specific reason for it. For example, if at all I am actually becoming very sedentary in my lifestyle, then I gain weight, it's fine. If I'm eating abnormally high and I'm gaining weight, it is also fine. But the patient is not having any change in his lifestyle. He has normal physical activity as always. He is eating his regular food as always. And in spite of that, he is having a weight gain. So something metabolically is wrong. This is what I have to make you understand. 5 kgs in the last 2 months. Occasional chest discomfort is seen, and especially when the patient is climbing stairs or performing strenuous activities. It means what? Previously, his ability of dealing with a particular condition was okay. Now he is not able to deal with the same physical stress. This is what you have to remember. Now look at the history part. No significant changes in his diet or physical activity level. The vital signs are showing you BP of 140 by 90 millimeters of mercury and heart rate is 76 beats per minute. Respiratory rate is 16 beats per minute. Temperature is 98.6 degrees Fahrenheit. So it is not very high grade fever, but you may be expecting some amount of fever. Here you'll be able to notice the cardiovascular system showing regular rate, rhythm, no murmurs, extra heart sounds. Here when I keep coming down towards the extremities, no edema or clubbing. Lab investigations are showing this kind of picture. Can you see the supernatant is actually creamy white in color? This is milky or creamy blood. Super natant is carrying the cream color. Imagine if it is shaken. If it is shaken, what is the color of the blood? In some questions, they will say creamy blood is accumulating. In some areas, they will say the blood is pink in color. And this is because of excess amount of chylomicrons in nature. Now have a look at this. Here they are proving that the triglycerides are 2000 milligrams per deciliter. It is a case of hyperchylomicronemia or hypertriglyceridemia. Now here you are seeing the phenotypes here. In case of Fredrickson's classification, we have type 1, type 2, type 3, type 4 and type 5. Now type 1 is focusing on triacylglycerols through the chylomicron pathway. Type 2 can actually have two types, type 2A and type 2B. In case of 2A, it is purely LDL. In case of 2B, it is LDL plus VLDL. In case of type 3, it is beta VLDL or IDL. Can anybody tell me what is the other name for IDL? Can anybody tell me what is the other name for IDL? See, intermediate density lipoprotein has another name. What is that? It is not a remnant of HAL, it is a remnant of VLDL. When VLDL is trying to become LDL, the intermediate step will be IDL. So you will be having the intermediate where the remnant is supposed to happen. Now this IDL is a remnant and you will be able to think of VLDL also having a remnant. That is, VLDL has a remnant and chylomicron also has a remnant. Excellent, Abhishek and Prem Kumar, they are remnants. Now whenever you have 3 as the disease, you may be having remnant disorder. Now 4 is purely VLDL and VLDL means to say triglycerides. Now let me say these two things very clearly and strongly. Whenever chylomicrons are increasing, technically triacylglycerol is increasing, and whenever VLDL is increasing, there also triacylglycerol is increasing. These are the two things that you have to remember. Triacylglycerol increases and it says both chylomicron and VLDL. Now what are the MCQs raised from here? Chylomicron is made up of 90% triacylglycerol. VLDL is made up of 60% triacylglycerol. Now whenever they speak about LDL, they are purely speaking about cholesterol. And why is it called as bad cholesterol? Because it is taking the cholesterol from the liver and depositing in the extrahepatic tissues. And why HDL is actually carrying cholesterol but still referred to as good cholesterol? Because it is carrying the cholesterol from the tissues and giving it to the liver. Who can manage cholesterol better? The liver. So liver is capable of managing it better, but not the blood vessel wall. That is why whenever LDL is pushing the cholesterol from the liver into the blood vessel wall, the blood vessel wall can go for atherosclerotic changes. Okay, now this is done. Now when you come for type 5, it can be either VLDL or chylomicron. Both of them are known to contain triglycerides, so it is also familial hypertriglyceridemia. Now let me erase these annotations. Watch very carefully. In type 5 and type 4, it is familial hypertriglyceridemia. In type 4, it is just VLDL. In case of type 5, it is both VLDL and chylomicron. In case of 3, it is familial dis-beta lipoproteinemia. Why do they call it that? Because we are focusing on ideal. Whenever we go for electrophoresis of these lipids, in the beta position, the VLDL will accumulate. So you call it as beta VLDL. Now when you go for type 2b, it is LDL plus VLDL, where it is called as combined hyperlipidemia. Why? Because LDL contains cholesterol, VLDL contains triglyceride. So both of them are elevated. It is combined hyperlipidemia. How is it different in case of type 4 and type 5? In type 4 and type 5, it is purely triglyceride. In type 1, that is also triglyceride. In type 2A, it is purely cholesterol. Now let me show you a few cases here. Now look at this. Can you tell me what this is? Can you tell me what this picture is showing? No, Saravanan, it is not abscess. Anything else? Okay, let me put it in a very simple fashion. What you are seeing here, excellent Darshini and Prem Kumar. See, all of them are xanthomas. Now using xanthomas, you should be able to crack the question. Using just the word xanthoma, you should be able to crack the question. How? See, the xanthomas can be of different types. What you are seeing here are eruptive. Here and the Achilles tendon, it's called as tendinous. Now these are tuberous, and these can be present in non-specific fashion. Now whenever there is eruptive xanthoma, it is purely triacylglycerol. So whenever you see eruptive xanthomas in a patient, you should be able to understand that we are dealing with either type 1 where chylomicrons are involved, or type 2b where there is combined hyperlipidemia, or type 4 or type 5. Now let me erase these annotations once again. Now look at this, it becomes easier for you. Type 1 contains chylomicron, you will be having chylomicronemia syndrome. Type 4 and type 5 both are containing triglycerides, and type 2b contains hyperlipidemia because of VLDL also. So in all these conditions, you can have eruptive xanthoma. But what is the tuberous xanthoma capable of showing you? See, this is tuberous xanthoma, this is tendinous xanthoma. Both of them indicate hypercholesterolemia. I'll write it here. Both of them indicate hypercholesterolemia. Both of them indicate hypercholesterolemia. We have tuberous xanthoma, we have tendinous xanthoma. Both of them indicate hypercholesterolemia. Can anybody tell me one more type of xanthoma in hypercholesterolemia? What is this? Excellent, Krishna Priya, that is xanthelasma. What you have here is xanthelasma, where there is a change that has ever happened in the face. What is this? Very good, Stardust. Very good, Narendran. They are correct. Tell me, what are they? These are called as palmar xanthomas. So when you have palmar xanthomas, tendinous xanthomas, and we have tuberous xanthomas, in all the areas we have cholesterol accumulating. In all these areas we have cholesterol accumulating, and that would mean to say that LDL can be elevated. Now tell me, in these Fredrickson's classification, what can be elevated? You have type 2A and type 2B. In both these conditions, LDL can be elevated. So here you will be able to see the tendinous xanthoma, tuberous xanthoma and palmar xanthoma. Now look at this part. When we speak of this question, here we saw the patient is having what xanthoma? In this patient, what xanthoma can be seen? Anybody? You already told me what is the diagnosis. Tell me what xanthomas are we seeing here or we should be expecting here? Excellent, Darshini. You will be expecting eruptive xanthomas. Correct. So if they say that, think of triglycerides. Okay. Now these are the different kinds of xanthomas. Now give me an answer for this question. This is hardcore metabolic place of lipids. Which of the following is not a feature of Jamaican vomiting sickness? Ingestion of ripe ackee fruit. This is unique, which causes unique lipid metabolic disorder, or profuse vomiting and altered mental status can be noticed. Seizures, hypothermia, coma and death can happen, and no specific antidote to the toxin is available. No specific antidote to the toxin is available. Which one is the right answer for this question? Yes. A. Okay, excellent. So this is a very simple question and the twist is placed in a very simple fashion. Why? Because when I put forward this, ingestion of unripe ackee fruit is the reason for Jamaican vomiting sickness. Now can you tell me what is the difference between unripe and ripe fruit? Ackee fruit, what is the difference between unripe and ripe ackee fruit? Unripe fruit is very rich in a compound called as hypoglycin, which is of two parts, A and B, out of which A is the serious culprit. Now hypoglycin A is named so because it is capable of causing hypoglycemia. It is known for causing hypoglycemia. Hypoglycin is known for causing hypoglycemia. That is the point. How? Because the hypoglycin is capable of inhibiting beta oxidation of fatty acids. It inhibits beta oxidation of fatty acids. Now people will raise question. If it is inhibiting beta oxidation of fatty acids, why am I going to suffer from hypoglycemia? The point is, when a patient is not having proper food, no proper food, and in Jamaica, if these people are depending on the ackee fruit for nutrition and with empty stomach in the fasting state, if at all the patient is eating the ackee fruit, the hypoglycin A will inhibit the beta oxidation of fatty acids. So the beta oxidation is not able to produce acetyl-CoA. And if acetyl-CoA is not able to come out, TCA cycle does not operate, and because of which ATP synthesis is not happening, the patient is already feeling very tired. And at that point of time, because you have not eaten food from outside, the exogenous source of glucose is not also happening. Now, this hypoglycin is capable of irritating your stomach mucosa, because of which profuse vomiting can happen, and because of consistent hypoglycemic state, mental status can be altered, and it can lead to seizures and hypothermia also. Now there is a question. Do you have a specific antidote for this toxin? Do you have a specific antidote for the toxin? Yes, this is a true statement. There is no specific antidote available. Then how do you treat the patient? By giving IV dextrose. Remember, dextrose is important for saving the patient at this point of time. Now, do you remember in India where exactly huge number of cases of metabolic encephalopathy happened in children because of lychee fruit ingestion? Because of lychee fruit ingestion. Ask yourself where it happened. You should be able to remember it, because in India there was a place where massive numbers of cases happen. Just search for it as a GK information. Okay, now tell me. Now this is about the glucose metabolism in terms of diabetes mellitus. When a patient is having diabetes mellitus, his physiological response will be affected. But normal physiological response, what do you think happens here? What is the first physiological response following hypoglycemia? Great, so Marhari. What is the first physiological response following hypoglycemia? When a patient is having less amount of glucose in his blood, what is the first response? Is it increase in cortisol? Is it decrease in insulin level? Is it increase in epinephrine? Is it increase in glucagon? Because all of them can actually raise the glucose values. But the point is, who happens to happen first? Who comes first? Sriram Balaji says increase in cortisol. Prem Kumar also says that. Stardust says B, decrease in insulin level. Darshini says A. Narendran says K. He says increase in epinephrine. Akshara says A. Vandergape says dextrose. Oh, Vandergape, I think you are slow in the answers. Okay, now remember this. This is one of the most common, simplest questions. People have made mistakes, because of which they have affected themselves very badly. Now just wait. In the next 5 to 6 minutes, we'll be going for inborn errors of metabolism in pediatrics, where we'll try to answer biochemical basis of many kind of sphingolipidosis and difficult questions. Now here, remember, the first physiological response whenever there is hypoglycemia is decrease in insulin level. Now let me write this as a flow chart here. Now imagine if the glucose levels are falling. If the glucose levels are falling, because glucose is the sensor and the stimulus for the insulin release. Whenever I eat a lot of food, the food has gone inside in the blood, the glucose is boiling. Because the glucose is boiling, high levels of glucose through the blood will go and activate whom? Can anybody tell me? Can anybody tell me high levels of glucose will be sensed by which GLUT receptors? Radhika Jutur, it is made up of all questions. We are beginning with that of lipid metabolism. Can anybody tell me, if glucose levels are high when I have eaten food at the end of the meal, I am very satisfied, which GLUT receptors will be able to identify the glucose levels are higher? Excellent Mukundan, excellent Sriram Balaji and Prem Kumar. Remember, GLUT2 is activated when the glucose levels are very high. How? Because GLUT2 has low affinity for glucose. GLUT2 has low affinity for glucose. GLUT2 has low affinity for glucose, and because of which you have to remember, only when high levels of glucose are being reached, you will be able to have the activation of GLUT. Because of which, when the GLUT is activated, you will be able to have the pancreas receiving the information. Now the pancreatic beta cells will start secreting insulin. The pancreatic beta cells will start secreting insulin. Remember this for the rest of your life. Whenever you have eaten very well, when the glucose levels are rising, GLUT2 is activated. The GLUT2 that is present in the beta cells of pancreas will make the insulin come out into a fashion. So insulin rushes into the blood to control the glucose. Now when the glucose levels are falling, the same GLUT2 will be deactivated. So because of which pancreas is not receiving any more signal. So insulin release will be blocked. Because of which decrease in the insulin level is the first response. Now what happens in case of diabetes mellitus? In diabetes mellitus, this response will be broken. That is why you may be having haphazard glucose levels. Haphazard glucose levels. Sri Rambalaji, very good. You have very high Km value. No, Abhishek, it is GLUT2. So make sure you remember this. GLUT2 will be activated. Okay. Now, what happens after that? Instantly, who is the header hormone which fights directly against insulin? Once the insulin's activity is shuttled or it is shut down, now who is the direct header of insulin? Who fights exactly opposite to insulin? Excellent, Prem Kumar and Darshini. So whenever the insulin level is falling, the glucagon will rise. So glucagon will rise. Glucagon will do its best in efforts to break down the glycogen. So glucagon will break down the glycogen and release glucose. And when enough amount of glycogen is actually releasing glucose, to support glucagon, epinephrine comes into picture. So the order is like this. First B happens, decrease in insulin. Next is D happens, there is increase in glucagon, and that is supported by epinephrine. So C happens, and finally when you have been stressed for a long time, D also will happen. And these D, C and A. So D, C and A, all of the three are capable of causing glycogenolysis. Glycogenolysis can exist for how many hours? Can anybody tell me? Can anyone tell me glycogenolysis can exist for how much time? This is another MCQ. Glycogenolysis can exist for a maximum of 16 hours. After 16 hours, yes, Saravana Kishore, 12 to 16, after 16 hours, your gluconeogenesis will come into picture. Your gluconeogenesis will come into picture. And once gluconeogenesis is done, then fatty acid breakdown happens, or beta oxidation of fatty acids increase. Remember, yes, that's correct. Now have a look at this. The early fasting state, the blood glucose starts falling several hours after the meal. So fall in insulin secretion or rise in glucagon secretion. Glucagon is secreted by the alpha cells of the pancreas in response to falling glucose levels in the fasting state. So whenever insulin levels are high, it's an indication for the fed state. Now can anybody tell me if the patient is, see, in fed state, the glucose levels are high, because of which insulin will be activated. Understandable. Yes, absolutely understandable. Now can you tell me, the glucose levels are high, but even in the non-fed state, the glucose levels are high and the insulin levels are also high. When? See, in the fed state, you will be having glucose levels elevated, insulin levels also elevated. Now can you tell me, the glucose levels are elevated, insulin levels are elevated, but it's a non-fed state. Which condition? Yes, what is the condition? Saravana Krishnan is absolutely correct. The answer is diabetes mellitus type 2. In that type 2, there are two types. Can anybody tell me what are the two types of diabetes mellitus type 2? Excellent. See, what are the types of diabetes mellitus? We have type 1, we have type 2, and we have maturity onset of diabetes in the young, and we have latency associated diabetes in the adults. We have type 1, type 2, MODY and LADA. Now out of which this type 2, I'll just give you a gist of whatever they are. Excellent, all of you are correct. It is type 2 diabetes mellitus. For those people who just said diabetes mellitus, remember it is not just diabetes mellitus. You have to be very specific about what I'm saying. In type 1, there is exhaustion. There is exhaustion of beta cells of pancreas. So insulin levels have failed. Insulin has failed. So whenever there is exhaustion of beta cells of pancreas, insulin has failed. Now maturity onset of diabetes in the young and latency associated diabetes in the adults, both of them are slightly different. These are because of gene mutations. And this one is also an insulin deficiency state. It is latent. you have been living with low amounts of insulin for a while, but your body was able to compensate with whatever insulin was available. But when there is a severe stress that happens on the patient, if he is able to exhaust all this insulin reserve, then LADA can become type 1 diabetes. So remember, LADA has clinical features of diabetes mellitus type 2. For those people where diabetes is still not done, please make a note of this. The clinical features of LADA is diabetes mellitus type 2. The clinical features of LADA is similar to diabetes mellitus type 2, but the problem in case of LADA is that of diabetes mellitus type 1. So can anybody tell me what is the other name of LADA? Can anybody tell me what is the other name of LADA? LADA is referred to as 1.5 diabetes mellitus. It is type 1.5 diabetes mellitus. Now let me give you a very important concept. This may not be taught much in your classes. For that reason, let me tell you this. See, previously type 1 was referred to as insulin dependent diabetes mellitus. Type 2 was referred to as non-insulin dependent diabetes mellitus. Type 1 was referred to as insulin dependent diabetes mellitus and type 2 as non-insulin dependent diabetes mellitus. Now they are not supposed to use these names. It is banned, contraindicated. Why? Now when they ask you such a question, you may actually start thinking of different answers. See, in type 1, insulin is less. So when you give insulin, the treatment is done. In case of type 2, there is resistance to insulin. In type 2, there is resistance to insulin. Now, you call it as non-insulin dependent. Why should you not give them the name? Because in type 2, there are two types. In type 2, one type says there is actual insulin resistance, and in the other type, there is defective release of insulin. There is defective release of insulin. Now, when there is a problem with type 2 where there is a defective release of insulin, you will be giving secretagogues like sulfonylureas where they are capable of releasing the insulin from the beta cells of pancreas. Now, how do you differentiate between the absence of insulin in case of type 1 and absence of insulin in case of type 2? In case of type 1 and in case of type 2b, I'll just call it as type 2a, I'll call this as type 2b. Between that of type 1 and type 2b, what is type 1? There is a reduced amount of insulin. What happens in case of type 2b? There is a defective release of insulin, so insulin is not there in the blood. So when I try to see blood insulin levels, in type 1 also it is lesser, in type 2 also it is lesser. But when I ask you one more question, total body insulin. If I look for total body insulin, the point of concern is total body insulin will be lesser, still lesser in case of type 1 diabetes, but it will be normal in case of type 2b. Why? Because the beta cells are still retaining the insulin. They are not able to liberate the insulin out. So total body content of insulin is normal, but the amount of insulin present in the blood is lesser. So total insulin in the blood is lesser for both type 1 and type 2b. Now what happens in type 2a? In type 2a, there is insulin resistance, because of which you will be able to keeping on activating the receptor, so you keep on producing more and more insulin, so insulin levels will be higher also. Now coming to the point, why I should not call type 1 as IDDM and why I don't call it type 2 as NIDDM. See, if I think of this type 1 and 2 as IDDM and NIDDM, we convert and forget the concept of LADA. Now tell me, in LADA, what is the insulin levels, high or low? I've told you already enough information. Tell me, in type LADA, what is the insulin levels, low or high? In LADA, what is the insulin levels, low or high? Yes, if a patient is suffering from LADA, he is having low insulin, and this insulin levels may be normal in the blood. Remember, may be normal in the blood, but the pancreas are already containing less amount of insulin. Now, if at all the clinical features are similar to what I told you, LADA's clinical features are similar to what I told you. Come on, people. Clinical features of LADA similar to type 2. Now in type 2, will you give insulin? No. In type 2, no insulin. So if at all the LADA's clinical features are similar to type 2, you will call LADA also as what? What was the old name of type 2 I said? The old name of type 2 is non-insulin dependent diabetes mellitus. Because if you find LADA to have similar clinical features of type 2, then LADA also will come under non-insulin dependent diabetes mellitus. So it means insulin is not the treatment for type 2 diabetes mellitus. So insulin will not be given in case of LADA. But what is LADA? LADA is latency associated. It means it is waiting for the right time to completely blow off. It is waiting for the right time to fail completely. It is waiting for the right time to fail completely so that it can go back to the stage of type 1. What is the treatment of type 1? Offering insulin. What is the treatment for type 2? Not offering insulin. Now you are going for secretagogue activity because insulin is already there or normal in type 2, but insulin may not be the treatment in case of type 2. Mainline treatment of type 2 is not insulin. Mainline treatment of type 1 is insulin. Now if you call LADA also as NADDM, you will not be giving insulin to LADA. Now when you don't give insulin to LADA, now those patients are under stress. When no insulin is given in LADA, that stress will make sure LADA turns into type 1. Now that person who was suffering from diabetes mellitus in a latent fashion will become overt diabetes mellitus patients. Now it means when a patient came to you with LADA, you did not know that he was actually not to be called as NADDM. You did not put him on insulin, because of which he had to exhaust all his insulin to maintain normal life. What you could have done, if you had named LADA as 1.5 and you had given him insulin from outside, the exogenous insulin will make sure his insulin is not used. The exogenous insulin will make sure his insulin is intact. At that point of time, he'll continue to remain as LADA, but the exogenous insulin will take care of his condition, so he'll be living a normal life. But because you started calling these as non-insulin dependent diabetes mellitus, you did not give insulin, because of which the patient had to exhaust his own insulin reserve. Now the LADA patients became type 1 diabetes. So in front of your eyes, under your watch, you let a LADA patient become a type 1 diabetes patient. That is what is a huge mistake of a doctor. And you should not be doing this. That is why you should not be using IDDM or NADDM anymore. You should start using the exact words. Now let me say that classification once again. See, type 1 is exhaustion of beta cells of pancreas. Insulin levels are lesser. Type 2 can be of two types. What are the two types of type 2? In case of type 2, either there is insulin resistance or there is decreased secretion of insulin. So in both the conditions, you are not able to handle the glucose. You have MODY, which is because of gene mutation. You have LADA, which is actually waiting to become type 1. There is one more type of diabetes mellitus, which is gestational diabetes mellitus. The other type is gestational diabetes mellitus. Now, did all of you understand why we are not supposed to use it? Please let me know now. Yes, Krishna Priya, we can go for checking of the insulin levels. Very good. Now, can you please tell me, did you understand why we should not call type 1 as IDDM and type 2 as NIDDM? Just say yes or no. Okay, now let's go to the next slide. Now answer this question. We'll see whether you can answer this question. If a patient is being given N-acetylcysteine, it is meant to replenish which of the following compounds? Thank you all of you. Thank you Stardust, Akshalakshmi, Snehalakshmi, Human Nature, Abhishek, Krishna Priya, Mukundan, Darshini, Ajay Vijakshan, Prem Kumar, Pulse Physician, Milophile, Zainab, Stardust, Narendran. Yes, thank you very much. Okay, now that's a very simple question, isn't it? Why the question is very simple? Because I made a straightforward connection. Now, can you tell me in which patients will you be giving N-acetylated cysteine? Let me tell you this. Paracetamol has a scientific name. What is it? It is acetaminophen. How do you handle acetaminophen? By reductive process, and you'll be using glutathione and convert them into NAPK, N-acetyl benzoquinonamine derivatives. Now, if a patient, excellent Stardust, if a patient has taken extraordinary amount of paracetamol, where he has taken more than 8 grams per day of paracetamol, then there is a sudden exhaustion of the reserves of GSH. Now, what is the relationship between GSH and N-acetylcysteine? Remember, gamma glutamyl cystinyl glycine is the full form of glutathione. Now this is called as a tripeptide. A tripeptide is made up of 3 amino acids here, but not 3 peptide bonds. You have only 2 peptide bonds but 3 amino acids. It is a tripeptide. This is an MCQ. If they ask you what kind of peptide it is, the answer is tripeptide. Also, it is also referred to as a pseudopeptide. Why is it a pseudopeptide? Two important MCQs which were asked in INICET and NEET exam. Why is it called as a pseudopeptide? Why is it referred to as a pseudopeptide? Remember, whenever there is an amino acid making a bond with another amino acid to form a peptide chain, whenever peptide chains have to be formed, you will always have alpha amino acids in the alpha amino acid linkage. But for the first time you're seeing cysteine and glycine can have alpha amino acid linkage, but you will be forming the cysteine's bond with the glutamic acid in the gamma carbon. Normally, alpha position is where you will be able to have a bond formation. Here it is happening in the gamma position, so you call it a pseudopeptide. Now, when you offer the cysteine from outside, you will be able to replenish. How? See, we all know that this cysteine, N-acetylcysteine, is the antidote for paracetamol poisoning, so that you can replenish glutathione reserves, isn't it? So why exactly? Because gamma glutamyl cystinyl glycine means the cysteine's sulfhydryl group is free. Now I can draw one more compound like this, gamma glutamyl cystinyl glycine. Another free sulfhydryl group is present. Now this is one molecule of GSH and this is another molecule of GSH. When both of them are coming together, the H will go to X, the H will go to X, the X is said to be reduced to become XH2. X becomes XH2. The X is said to be reduced. Now who is this reduced component? This excess amount of paracetamol requires a special form of reducing agent called as glutathione. Now what happens here? I'll erase this area. Now you have lost the sulfhydryl group from here, the hydrogen from here and hydrogen from here. There is a bond between sulfur and sulfur. Now this compound is referred to as oxidized glutathione. Now why are you giving N-acetylcysteine? The N-acetylcysteine will be able to offer fresh SH group. So when two molecules of SH groups are coming here, now this will break the bond here, because of which the hydrogen from the cysteine will come here, so that this SH and this SH will be replenished, so that more amount of paracetamol can be dealt with. Can N-acetylcysteine deal with paracetamol directly? Anybody? You are giving N-acetylcysteine in paracetamol poisoning. Can N-acetylcysteine treat the paracetamol? No, N-acetylcysteine cannot deal with the paracetamol, while N-acetylcysteine can deal with the glutathione, so it can convert the GSHG into 2 molecules of GSH, because of which the GSH will be ready to deal with more amount of paracetamol. That's all. Now let's look at this important information. Now let's have some important pointers. This will be very essential for your INICET exam. This is a collection of multiple data. MUFA is monounsaturated fatty acid. The highest content of MUFA is mustard oil, rapeseed oil. The highest content of MCFA, medium chain fatty acid, would be coconut oil. Highest content of linoleic acid is safflower oil. This is very important. Why? Because linoleic acid is the most important essential fatty acid. The most important essential fatty acid is linoleic acid, and that linoleic acid, the highest content of linoleic acid is present in safflower oil. Safflower oil is also the source of PUFA. So remember, people will ask you about safflower oil. Safflower oil is a very important source of PUFA and linoleic acid. Remember, the most essential fatty acid is linoleic. The next essential is linolenic. First one is linoleic, then linolenic. Remember this, linoleic and then linolenic. Arachidonic acid is semi-essential. Arachidonic acid is semi-essential. Now they ask you, what is the second most common source of PUFA? Now comes sunflower. All of us learn about sunflower, and we all will be using sunflower oil in our homes for cooking. In Kerala, they'll be using coconut oil also for cooking. Coconut oil is also very healthy for food. Why? Because when you have long chain fatty acids, you have to go through the carnitine palmitoyl transferase enzymatic activity to enter into the mitochondria. Remember, long chain fatty acids also are burnt in the mitochondria. Medium chain fatty acids are also burnt in the mitochondria. Short chain fatty acids also can be burnt in the mitochondria. But for short chain fatty acids and for medium chain fatty acids, you don't require the carnitine palmitoyl transferase or carnitine acetyltransferase enzyme. They can go without any kind of mediators. That is why if you eat a lot of ghee, butter, you don't have to worry much about it, because they are not as dangerous as palmitic acid or palm oil. Why? Because they can be easily burnt by the mitochondria. Okay, now when they ask you what is the most common or what is the least source of PUFA, the answer is again coconut oil. When they ask you at times why coconut oil can be dangerous, if you take excess amount of coconut oil is very good, healthy, but if you take excess amount of coconut oil, why is it dangerous? Because the content of PUFA is the minimum in case of coconut oil. Now remember, when it comes to fish oils, what are the most important acids you have to consider? In case of fish oils, the most important things to consider would be timnodonic acid, clopidogrelic acid and cervonic acid. Now, can anybody tell me what is this? This is docosa hexaenoic acid, which is very essential in the mother's milk. And this is important for CNS development. This is important for CNS development. Mother's milk and CNS development. These are the two important pointers you have to take home from this particular session. Okay, now let's change the slide. Now, can you tell me the answer of this question? This is A, this is B, this is C, and this is D. Yes, Stardust. Arachidonic acid can be obtained from the phospholipid bilayer membrane. It can also be converted from linolenic acid. That is why, by extension of the 18-carbon compound called as linolenic acid, you will be able to produce arachidonic acid by extension of the long chain. At the same time, by breaking the by breaking the phospholipid bilayer membrane also, you can get arachidonic acid. So it is semi-essential. Now, can you tell me what is the answer of this question? Let me tell you the most important keywords here. We are dealing with an infant. The motor skills are poor. The startle reaction is very high and seen as a response to even mild sounds. Remember, whenever you have increased startle reaction seen as a response to even mild sounds, this is referred to as hyperacusis. In applied anatomy and in case of ENT, you will come across this sentence. Hyperacusis can be a property of stapedius paralysis. Do you remember this? Hyperacusis can be seen as a property of stapedius paralysis in both ENT and anatomy. Now the same hyperacusis is happening in this case. Now look at the most important points. We have macrocephaly, the skull has increased in size. We have hepatosplenomegaly, and we have non-specific cardiac and mild bony abnormalities. When I say non-specific cardiac abnormality, we have ruled out the specific cardiac abnormality causing lysosomal disorder. See, there is a disease called as lysosomal storage disease, where you will be having specifically cardiac disorder in mucopolysaccharidosis. Which one is that? Anybody? Quick guesses? Come on people, quick guesses. In a mucopolysaccharidosis, a specific cardiac anomaly is noticed. Which one is that? Excellent, Saravana Kumar. It is Saravana Krishnan. It is Pompey's disease. Okay. So remember, it is Pompey's disease, and Pompey's disease is mucopolysaccharidosis. Mucopolysaccharidosis, which happens because of accumulation of mucopolysaccharides you're not able to break down. It is a carbohydrate metabolic disorder. Now this is also running parallel to carbohydrate metabolic disorder, but can you give me one general examination finding which can not focus this on mucopolysaccharidosis? Can you give me one clinical feature which can differentiate this mucopolysaccharidosis from the condition that we are discussing about? I'll erase all these. Anybody? That clinical features is coarse facies. The face looks very coarse, rough and thick, and accumulation of mucopolysaccharides happen. Now this is a property of mucopolysaccharidosis condition. Okay, now if there is a same accumulation of mucopolysaccharides in the interstitium and there is poor knee jerk reflex, what is it referred to as? It's an indication of what in pediatrics or in medicine also? See, in mucopolysaccharidosis, there is accumulation of mucopolysaccharides. If it happens in the face, the child's face appears more thicker and it looks very coarse. It's an indication for mucopolysaccharidosis. The same accumulation of mucopolysaccharides are happening in the lower limb, because of which there is poor knee jerk reflex. What do you understand from that? What is the diagnosis? The diagnosis would be myxedema. Myxedema is a property of hypothyroidism. From now onwards, there will be seamless integration between that of basic sciences and clinical classes. So clinical discussions. Remember, in case of hypothyroidism, the T3 levels are lesser. T4 is also lesser, but T3 being lesser is the most important thing. So when T3 is lesser, the metabolic reactions are becoming slower, so catabolism is lesser. And when catabolism is lesser, clearance of mucopolysaccharides become lesser. The mucopolysaccharides accumulate all over the body, especially in the lower limb, because of which there is a poor response to the knee jerk reflex. This is referred to as myxedema. And when that patient becomes unresponsive, he is having CNS changes and unresponsive. What is that acute condition referred to as? What is that acute condition referred to as? If hypothyroidism has become very severe, myxedema has become very severe, CNS changes are noticed, what is that referred to as? When CNS changes are happening in hypothyroidism, what is it referred to as? It is referred to as myxedema coma. Okay, it is referred to as myxedema coma. Excellent, Akshara. That is the right answer. Now try to keep all of them into consideration here. Do you find coarse facies here? In this case, there is no coarse facies. So you can keep the mucopolysaccharides option to be lesser possibility. Okay, excellent, Prem Kumar. That is also right. Excellent, Krishna Priya. Good. Now the possibility is lesser. Now here, look at this. The cardiac anomaly is non-specific and there is mild bony anomaly. Which kind of accumulation disorder is capable of attacking the bone? Also see, there is a pale macula, cherry red spots are seen. So now bone anomaly is seen plus cherry red spot is seen. And the attending pediatrician is telling you the death of the infant is inevitable. You can't actually change it. By the age of 4 to 5, he has to die. Among the following, think of the bone anomaly. Now let me give you a clue. In case of bone anomaly, you can actually have the accumulation in such a way. The accumulation happening in such a way, the cardiac anomaly is non-specific. Excellent, Darshini, Prem Kumar, Krishna Priya, Akshara Bimal, all of you are saying Gaucher's disease. If it is Gaucher's disease, what do you think is the answer here? What should have been the enzyme? If it is Gaucher's, what should have been the enzyme? If it was Gaucher's, you should look at beta glucosidase or beta glucocerebrosidase. I have intentionally given only beta galactosidase in both the conditions, so it cannot be Gaucher's disease because of elimination from the option. Now look at this part. Now the answer is beta hexosaminidase A or A and B, which can be Tay-Sachs disease. The answer here, I'll just mark it here. The answer is this. Now, shall I teach you? If you're okay, shall I teach you how exactly you can actually learn all of them in one single slide? Is it okay? In one slide, is it okay if I teach you this? Stardust, you have to actually choose only beta glucosidase or beta glucocerebrosidase. Okay, now look at this slide. Just a moment, please. You can search for this in the Google itself. Okay, dear students, I request you for only one thing. Just give me your patience and your time for the next 10 minutes. Exactly 10 minutes for this topic only. We can finish off everything related to this particular area called as sphingolipidosis. We'll make sure we can learn about sphingolipidosis in toto in the most comprehensive manner. Just give me your patience and your thought process. I'll make sure that you'll be able to have this time worth your while. Okay. Now, what is sphingolipidosis? The sphingolipids are accumulating. Now, what are the two types of compound lipids? You can have nitrogen containing and non-nitrogen containing complex lipids. Now you can have glycerophospholipids, you can have sphingophospholipids. Yes, you have glycerophospholipids and sphingolipids. phospholipids. Now when you think of glycerophospholipids, the backbone is glycerol. When you focus on sphingophospholipids, the sphingosine is the backbone. Sphingosine is the alcohol. Now what is the difference between sphingosine and glycerol? Glycerol is a simple 3-carbon trihydroxy alcohol, but sphingosine is a complex alcohol. It contains amino group. Sphingosine is an amino alcohol, so remember that part. Now let me go simpler here. Now first we'll start here. We'll do chemistry and this parallelly. We'll do chemistry and the sphingolipidosis parallelly. In this picture, we are having sphingosine. Now, if sphingosine is reacting with one fatty acid, both of them will form a compound called as ceramide. When sphingosine plus fatty acid is formed, it forms ceramide. So when I break ceramide, I will be getting sphingosine plus fatty acid. That's all. The simplest first step is when I start with sphingosine plus fatty acid gives you ceramide. If you break ceramide, it gives you sphingosine plus fatty acid. Now you will be having the reaction written in the backward direction, right? So when ceramide is broken down into sphingosine and fatty acid, the enzyme is ceramidase. Now if that ceramidase is deficient, then what will accumulate? Ceramide accumulates. Now when ceramide accumulates, it's called as Farber's disease. When ceramide accumulates, it's called as Farber's disease, and the deficiency is the enzyme ceramidase. If ceramidase is not present, ceramide accumulates. So sphingosine is not very high in nature. Fatty acid is also not very high in nature. Is this fine? Did you understand till now? I have just begun. If you are okay at this particular speed, we can continue. Is it okay? Excellent human nature. It is called as human nature. It is amino alcohol. Correct. Thank you, Dr. Abhirami. Thank you all the doctors over here. Yes, now we are going to start the whole process from here, that is ceramide. Now look at this. Here I'll be trying to add glucose to the ceramide. The glucose plus ceramide will give rise to glucose containing ceramide, which has another name called as glucocerebroside. Cerebroside means nothing but a ceramide along with that of a monosaccharide. See, whenever you use the word cerebroside, cerebroside means a ceramide plus a monosaccharide. A ceramide plus a monosaccharide is called as cerebroside. If that monosaccharide is glucose, you call it as glucocerebroside. If that monosaccharide is galactose, it is galactocerebroside. We have ceramide here. Ceramide plus glucose is glucocerebroside. Ceramide plus galactose is galactocerebroside. Now both of them are present here. Now at this range, you can actually come back to the disorder that can actually be present here. Now be it a glucocerebroside or a galactocerebroside, if you don't have a glucocerebrosidase enzyme, then glucocerebroside accumulates. If I don't have a beta galactocerebrosidase enzyme, then galactoceramide will accumulate. Now, if it is galactocerebroside accumulating, the enzyme defective is galactocerebrosidase. The enzyme is galactocerebrosidase, which is deficient. So if galactocerebrosidase is deficient, Krabbe's disease is seen. If glucocerebrosidase is deficient, Gaucher's disease is seen. Now what is the difference? In case of Gaucher's disease, glucocerebroside accumulates. Where does that accumulate? It can happen in different parts of your body. Sometimes some authors will say it can actually happen in the liver, so hepatosplenomegaly can happen. At the same time, this glucocerebroside can accumulate in the bone, and the bone goes into deformity, and when the bone deformity happens, you can have Erlen-Meyer flask deformity. This is an important MCQ. It has been asked 7 times in INICET, that is in JIPMER exams, in AIMS exam, and PJ Chandigarh exams. In multiple exams they have seen. So remember, Erlen-Meyer flask deformity can be seen. I'll show you the picture how the bone looks like. The bone looks like a flask. Erlenmeyer flask deformity can be seen. Now this is a radiological understanding. Now what happens at the cytological level in the bone marrow? In the bone marrow, glucocerebrosides will accumulate. Glucocerebrosides accumulate in the bone marrow and they will cause foamy macrophages. Why? Because the macrophages are filled with the globocerebrosides or glucocerebrosides, because of which you will be having foamy macrophages which are replacing the bone cells like stem cells. Now it can lead to pancytopenia. Pancytopenia means the erythrocytic precursors will be knocked off, because of which you'll have anemia. WBCs also will be knocked off, because of which you may be prone for more infections. That is why the child will not be able to cross 4 or 5 years of age. And the third thing is thrombocytic precursors also will be destroyed. So thrombocytopenia can be seen. So platelets will become lesser, because of which the patient will have bleeding diathesis. Now all these things can happen, and when the glucocerebrosides are accumulating in the bone marrow, it will give you an appearance which is referred to as crumpled tissue paper appearance. This is not very specific for Gaucher's disease, but it is definitely found in Gaucher's disease. So two important keywords you realize. One is the foamy macrophages causing the crumpled tissue appearance in the bone marrow tissue, and also you will be having the glucocerebrosides capable of changing the bone architecture, because of which Erlenmeyer flask deformity can be noticed. Now the same thing can accumulate in the retina also, because of which cherry red spot can be noticed. In the retina, cherry red spot can be noticed. Now there are some MCQs. Where do you find cherry red spots and where you don't find cherry red spots? Now there is a common understanding that cherry red spots may not be found in Farber's disease, Krabbe's disease, and can you name one more disease? Yes, in case of Gaucher also some people say. F, K and G, 3 areas where some authors will say cherry red spots may not be seen, but it has been proven very strongly that in Krabbe's also there are cherry red spots. In some conditions, Farber's galactocerebrosidasis are the condition, or mucolipidosis, right? Remember this? Farber's mucolipidosis, you will not be having cherry red spot. So at this point of time, there are two conditions where you can safely say cherry red spots can be noticed. One is Farber, the other one is Gaucher. Krabbe's, it can be present, may not be present. Now in our case, it was not actually the Gaucher because of one reason. Now look at this case discussion here. I had said cherry red spots are seen in the retina. That is why we have to rule out the Gaucher's disease. And one more thing, in the options I did not give beta glucocerebrosidase. That is why you cannot choose Gaucher's disease also. Okay, now let's continue with this. We can now, because this is already done, it will become faster for you. Shall we continue? Yes. Now, whenever the galactoceramide is accumulating as galactocerebroside, it is because of deficiency of beta galactosidase or galactocerebrosidase enzyme, which is called as Krabbe's disease. That is also a very rare disorder. The patient actually will not be able to survive more than 4 years of age. Now, try to build upwards. We have ceramide. To the ceramide, I am adding glucose. That is glucoceramide or glucocerebroside. Now, if I add one more hexose called as galactose, it is having the glucocerebroside called as ceramide plus glucose, to which a galactose is added. Now, when I have a glucocerebroside plus a monosaccharide, it becomes a globoside. A cerebroside turns into a globoside if you add one more hexose. So now let me erase these annotations for it to be easier for you to understand. Look at this. Here we have ceramide. Ceramide plus one monosaccharide becomes cerebroside. Cerebroside plus one more monosaccharide becomes globoside. Now you have glucose, galactose, both of them present in this. It is a globoside. Now, if I keep on building upwards to the globoside, if I add N-acetylnuraminic acid, N-acetylnuraminic acid, it is NANA. This is also referred to as sialic acid. Now to the globoside, if I add 1 nana, that becomes ganglioside. So I'll erase this. We'll make it very simple again. We have glucocerebroside. Now one more monosaccharide makes it globoside. Globoside plus nana, also referred to as sialic acid in this condition, can give you ganglioside. Now this ganglioside will actually be made up of ceramide, glucose, galactose, nana. Now the next addition is here. Now if I add one more thing, look at this part here. Now to the existing condition called as ganglioside called as GM3, if I add GalNAc, this is N-acetyl galactosamine, then that is called as GM2. To that N-acetyl galactosamine, if I add a galactose, that is called as GM1. See, I can tell you this with all the love in my heart. It will definitely take a lot of effort on your side if you want to read all these things clearly, legibly, so that you can use it in exams. It takes a lot of time. But if you're sitting here with me, I asked you for 10 minutes. Now exactly 10 minutes are done. Since the time I asked you for 10 minutes, now it should be easier for you. Keep following me. We'll repeat whatever we have learned here. Simple. Start with ceramide. Ceramide plus monosaccharide, or this monosaccharide will give you a cerebroside. If it is glucose, it is glucocerebroside. If it is galactose, it is galactocerebroside. Now, if this enzyme is deficient, this will accumulate. If this enzyme is deficient, this will accumulate. That's all. Now, if glucocerebroside will get one more monosaccharide like this, it becomes globoside. To a globoside, if I add nana, it becomes ganglioside called as GM3. Now to that ganglioside, if I add N-acetyl galactosamine, it becomes GM2. To the N-acetyl galactosamine, if I add galactose, it comes and bind here, it is called as GM1. So now, looking at these three structures, you tell me which one is the biggest molecule, GM1 or GM2 or GM3? Dear students, by looking at the three compounds called as GM1, GM2 and GM3, can you tell me which one is the biggest? Excellent. GM1 is the biggest. Now, what is the microbiology information you remember from GM1? What is the integration between biochemistry and microbiology here? Because what you learn is GM1 ganglioside receptor accepts which toxin? GM1 ganglioside receptor accepts which toxin? This is a very common MCQ. GM1 ganglioside receptor accepts which toxin? Excellent human nature, cholera toxin. Cholera toxin referred to as choleragen. Now, have you heard of GD1? We have GM1 here. Have you heard of GD1? Very correct, Krishna Priya, and human nature, you're correct. Yes, correct. Come on. Yes, correct. Do you know what is GD1? Okay, from now onwards, I'm pretty sure you would not have read it much, but if you know it, it's good. If you do not know it, it's also good because you're learning now. See, I told you, if we add one nana, the globoside becomes cerebroside. The globoside becomes ganglioside. By addition of a nana, you convert globo into ganglio. If it is one nana, it means M is mono. Mono speaks about one nana being added. If I add 2 nanas, it's called as GD, di. If I add 3 nanas, it is GT, tri. And if I add 4 nanas, it is GQ, quattro. So remember, if you come across GQ3 in the exam, it means they have added 4 nanas here, and you will not still be having the galnac and gal. Are you following this? Excellent human nature, very good. Okay, now let's move here. Look at this part. We have galnac added to the GM3 to become GM2. Now, if GM2 wants to become GM3, it has to lose what? If GM2 has to become GM3, it has to lose what? The galnac. Now, galnac means what? N-acetyl galactose amine. Now, why do you read all these names? And these names are slightly irritating for you because these names do not make exact sense. You just think that you have to remember them as it is. But remember, hexosaminidase has a meaning. When I draw a 6-carbon monosaccharide, it's an aldose sugar. It can be either glucose or it can be galactose. It is just a hexose. Now in the hexose, in one of the carbons, instead of having a OH, I knock off the H, or I knock off the OH, and I make an ammonia come and bind to this. It is called as aminated glucose or aminated galactose. Say if this is galactose, then it is aminated galactose, referred to as galactosamine. If it is glucose with amine group, it is called as glucosamine. But what is glucose and galactose put together? Hexose. Then that is referred to as hexosamine. Is that clear till now? Hexosamine means an amino group has been attached to the 6-carbon aldose sugar, either a glucose or a galactose in this condition. Now, in this amino group, I knock off the hydrogen and I make an acetyl group come and bind. Acetyl group is coming and binding. I'll write it here. We have a galactose. The galactose is containing a nitrogen. To that nitrogen, I'm adding acetyl group. So where is the acetyl group added? The acetyl group is bound to the galactose. It is bound where in the galactose? To the nitrogen. That is why I write it as N-acetylated galactose. But is it just galactose? Because the presence of nitrogen, it is not just galactose, it is galactosamine. Now, you look at the enzyme called as hexosamine. Now it is N-acetylated hexosamine, or you can just call it as hexosamidin. Now, look at this. This enzyme, hexosaminidase, has to break the bond here. If it breaks the bond here, galnac is liberated. If this is not being liberated, then GM2 will accumulate. So Tay-Sachs is an example of GM2 gangliosidosis. Did you understand this? Did you understand this? Tay-Sachs disease is an example of GM2 gangliosidosis. Yes or no? Okay, so now you have another question. See, sometimes you have hexosaminidase A, you also have hexosaminidase B. Now, when will you say A and B coming together? Look at this part. If hexosaminidase A and B, both of them are deficient, it's called as Sandoff-Jacquemus disease. What is the meaning of A and B, and what is the meaning of A? That by itself is another question. Now, look at this here. In this case, you have a globocyte. Now, this is not a ganglioside per se. This is not a ganglioside per se. This is a globocyte. Look at this. This is a globocyte. In case of a globocyte like this, if at all you remove the galnac from here, then when the galnac is gone, you will be able to have globotriacyl ceramide or ceramide trihexoside. Ceramide trihexoside can be added here. Look at this. I'm sorry, I'm not able to fit it inside the screen, but are you able to see this? On on this side we have a globoside. If a globoside loses galnac, it becomes a globothiacyl ceramide. If that enzyme is deficient, it's called as beta hexosaminidase A and B. If that is deficient, the condition is referred to as Sandoff disease. Now how do I remember? How do I remember? See, Te looks like tacky. Tacky means fast. Now when I'm galloping on a horse, on the horse I'm keeping two bags. Two bags are heavy. Now when the two bags are heavy, the horse is still trying to run fast, but it is not reaching optimal speed. So what do? I cut off them. I cut off one of them. If one of the bag is removed, one bag is available. Now imagine these bags as A and B. If B is removed with the A, now the horse speed increases. It's tacky horse. The horse is running very fast. So tacky looks like Te. Tay-Sachs disease is speaking about the absence of the enzyme hexosaminidase A. Now how do we remember Sandoff? Sandoff sounds like takeoff. Now takeoff means use it in case of flights or planes or aircraft. Now the aircraft will obviously be faster than a horse galloping. How can that happen? When you remove both the enzymes. If both of them are deficient, a person can. That is, if both the bags are removed, now the horse can fly. Sandoff, takeoff. So it means if both A and B are deficient, it is Sandoff disease. If only B is deficient and A is present, it can be Tay-Sachs disease. I am pretty sure it may be looking very lame. The story may look very lame and dumb, but whenever you make a story, make it so stupid in such a way that you will be able to go back and laugh at it. Okay? Have a look at this. Sandoff, takeoff, both of them are deficient. Tay-Sachs, tacky, fast, one bag is dropped, so the hexosaminidase A bag is dropped, B is retained. Did you understand this? Okay, now these are the diseases. What is Niemann-Pick disease? See, normally when you have choline plus phosphate plus ceramide. What is ceramide? Sphingosine plus fatty acid is ceramide. We saw it in the other end, to which I add a phosphate, to which I add a choline. The moment choline has come, it has become a nitrogen excess containing kind of lipid. So you have sphingomyelin. Sphingomyelin means sphingosine plus fatty acid plus phosphate plus choline. If I try to remove the phosphate plus choline, what I will be left with is ceramide. I'm coming from the other direction. In this direction, sphingosine plus fatty acid gives you ceramide. In this direction, sphingomyelin, when it loses the phosphocholine, that becomes ceramide, right? Now, this enzyme is sphingomyelinase. If that sphingomyelinase is absent, then Niemann-Pick disease is noticed. Niemann-Pick disease is noticed. Okay, now let's look at this. This is the slideshow that is must know for you for your exams. In case of Farber's disease, ceramidase is deficient. In case of Fabry's disease, alpha galactosidase is deficient. GM gangliosidosis we haven't discussed much, but you can actually learn it later. Tay-Sachs diseases, beta hexosaminidase A. Sandoff diseases, beta hexosaminidase A and B. Gaucher's diseases, beta glucosidase. Niemann-Pick diseases, sphingomyelinase. And now we left one important thing here. Look at this portion. We look at this portion. Here we have a ceramide. To the ceramide we add galactose, it becomes galactocerebroside. And now to the galactocerebroside, if I add a sulfate, it is sulfated galactoceramide, referred to as sulfatide. Sulfatide. Now here you have to remember the galactocerebroside, if it becomes sulfatide, it becomes galactocerebroside when the sulfate is lost. Now that sulfate is removed by the enzyme sulfatase A or cerebroside sulfatase. If that is deficient, there is accumulation of sulfatide. There is accumulation of sulfatide. That condition is called as metachromatic leukodystrophy. The condition is referred to as metachromatic leukodystrophy. We have discussed all of them together. Now in this case, because of the presence of cherry red spot, we are not going for Gaucher's disease. We go for beta hexosaminidase A and B. You have hepatomegaly, you have macrocephaly, and you have seizures. The seizures are not responding to anticonvulsant therapy. Think of Sandoff disease or Tay-Sachs disease. Do you have any questions in this case? Do you have any questions in this case? Wait for you. Please tell me. No questions. Excellent. Thank you very much. Yeah. Now, have you ever wondered why you use the word hexosaminidase A and B, and in case of Sandoff disease both A and B are deficient, in case of Tay-Sachs disease only A is deficient? Now look at this. This is a beautiful concept. See, when I look at the enzyme beta hexosaminidase A, when I look at the enzyme beta hexosaminidase A, this is an enzyme, right? Enzyme means it should have a minimum of 2 subunits. That is, it should actually maintain a secondary structure at the minimum most level. Now here, when you have only 2 subunits, you'll be able to construct a tertiary structure. I'm so sorry. I meant to say, if you want to have a protein that has to act as an enzyme, the minimum level of the structure to be maintained is tertiary structure. For tertiary structure to be present, you require a subunit. Now, more than 1 subunit should be present so that you will be able to have enzymatic activity to have a quaternary structure. But here, this beta hexosaminidase A is made up of 1 alpha subunit and 1 beta subunit. A hexosaminidase A enzyme is made up of, now if I draw this, you will be having A, alpha and beta subunit. When both of them are together, I'm so sorry, I'll erase this. I'll write it clearly. This is subunit alpha, subunit beta. When both of them are interacting, what I get is beta hexosaminidase A. Now, when you focus on beta hexosaminidase B, both of them are beta subunits. In case of hexosaminidase B, both of them are beta subunits. Now, whenever a patient is having a mutation and that mutation is affecting the alpha subunit, you tell me which one will be affected. This is beta hexosaminidase B. This is beta hexosaminidase A. Now you tell me, if the mutation happens to affect the alpha subunit, which enzyme will be affected, A or B? No, seizures can be seen in most of the sphingolipidosis, but they are more pronounced in case of Sandoff and Tay-Sachs disease, Prem Kumar. Now, can you tell me, if alpha subunit is affected, is it beta hexosaminidase A or B? Excellent, beta hexosaminidase A. Now, I say if the mutation affects the beta subunit, then it is affecting which one, A or B? If beta subunit is affected, it affects what, A or B? Human Nature, Sarana Krishnan, Stardust, Krishna Priya, Abhishek, Narendran, all of them are correct correctly. Very good. Now, give me the answer. If beta subunit is affected, is it hexosaminidase A or B? Done. That's all. Human Nature, Stardust, Narendran, Zainab, Krishna Priya, all of you are correct. It affects both. So remember, Whenever a patient is suffering from beta hexosaminidase B, it is defect of 2 beta subunit. If it is A, it can be alpha and beta. If alpha is affected, only A is there. If beta is affected, it can affect both A and B. So which one is more severe? Which one is more severe? Tay-Sachs or Sandoff? So which one will be more severe, Tay-Sachs or Sandoff? Excellent, Sandoff. Now look at this question. Now you should be able to answer this question. Come on. Disease X has a variable age of onset extending between very early childhood to late adulthood. History of bone pain and pathological fractures of long bones during the course of the disease is noticed. Chronic fatigue is seen. Severe pain in the bone and swelling occurs in the patient from time to time. On examination, hepatosplenomegaly is seen, but no mental retardation is noticed. Lab investigations are revealing presence of intracytoplasmic substrate inclusions in bone cells. The cytoplasm of those cells reacts strongly positive for PAS stain, that is periodic acid skip stain. Pancytopenia is noticed. Bleeding diathesis is noticed. Which of the following may not be a feature of the disease X? Is it crumpled tissue paper appearance? Is it Erlenmeyer flash deformity? Is miglustat the drug given for treatment? Choroid spot is seen in the macula. Which one is not a feature? A, B, C, D. Which one? You should be able to answer this. See, you would have made the diagnosis by the time, because we have done all these things. Now the question should become very easy for you. So the diagnosis should be made based on what and what. Look at this. Chronic fatigue is seen. Severe pain in the bone is seen. And substrate inclusions in the bone cells are seen. What is the diagnosis? Yes, the diagnosis is obviously Gaucher's. Now, if it is Gaucher's disease, now you tell me, can you see crumpled tissue paper appearance? Yes. Can you see Erlenmeyer flash deformity? Yes. Now, if you think between C and D, if you have a problem, we already discussed about D. Choroid spot, is it present in the macula in case of Gaucher's? Choroid spot, is it present in the macula in the Gaucher's disease? No. So by default, you are learning from this MCQ that miglustat may be a treatment for the Gaucher's disease. Miglustat may be a treatment for Gaucher's disease. Now look at this. For Gaucher's disease, enzyme replacement therapy can be done. That is, you are giving the enzymes for the patient where it is defective. Now what is imiglucerase, what is vilaglucerase, and what is taliglucerase? Both of them. All three of them. Yes, correct. Human nature. Very good. Fabry's. Yes, correct. In Farber's also you'll have it, but not in Fabry's disease. Human nature is correct. In Krabbe's disease, choroid spot may be seen, may not be seen. Remember, it may be or may not be seen. But in case of Fabry's disease and Gaucher's disease, it is not seen. Some people say in Farber, but no. In Farber's mucolipidosis, you can see choroid spot. Okay. Now here, look at this. See, acid beta glucosidase, if you offer to the patient, it is imiglucerase. If you take it as a source from human fibrosarcoma cells, it is velaglucerase. If it comes from carrot plant cells, it is taliglucerase. These are all treatment where you are replacing the enzyme itself. What else can be given? See, to treat Gaucher's disease, what else can be given? When in case of Gaucher's disease, there is accumulation of glucosyl ceramide, why don't you prevent the formation of glucosyl ceramide? Who is helping in the formation of glucosyl ceramide? It is the enzyme glucosyl ceramide synthase. Now, when you give the drug called as miglustat, miglustat inhibits glucosyl ceramide synthase, because of which glucosyl ceramide formation is inhibited, because of which you will be able to do it. See, either you give the enzyme in the form of glucocerebrosidase, which breaks the glucosyl ceramide. Look at this. Glucose plus ceramide will give you glucosyl ceramide, which is a glucocerebrosidase. The enzyme here is glucocerebroside synthase. Now it should be broken down. For breaking down, you require the enzyme beta glucosidase. Either you offer this enzyme so that this can be decreased, or you inhibit this enzyme because of which it is not being formed. These are new age questions. You have to know them for answering a question. Now, what is a Gaucher's cell? Gaucher's cell is seen in Gaucher's disease only. Is it true or false? See, crumpled tissue paper appearance can be because of Gaucher's cell, I told you. It is because of accumulation of lipid-filled macrophages, I've already told you. I'm asking you a simple question. So, if I see Gaucher's cell, what is a Gaucher's cell? It is presence of intracytoplasmic substrate inclusions in the bone cells with strong staining with PAS. That is the definition of Gaucher's cell. But the Gaucher's cell is not unique for Gaucher's disease. It is present in myeloma and leukemia also. The leukemia is a granulocytic leukemia. Myelocyte, it can be myeloma or it can be granulocytic leukemia. It can be present in both. Is that clear? Yeah. Now, this is called as Erlenmeyer flask deformity. Can you notice this? The bone looks like a flask. And in this case, you had bone pain. Remember? In this case, you had severe pain in the bone. The severe pain in the bone is because of accumulation of the macrophage filled with that of lipid, because of which an osteomyelitic pattern is seen, but there is no active inflammation of the bone. So this is referred to as pseudo-osteomyelitic pattern. This is referred to as pseudo-osteomyelitic pattern. This can also be seen in case of Gaucher's disease. We have spent considerable amount of time in sphingolipidosis, around 40 minutes here totally, because there have been totally 94 MCQs in the last 7 years. In the last 7 years, before INICET came into existence, INICET, the first INICET happened in September 20th of 2020. 20th September 2020 was the first INICET. Before it became INICET, it was JIPMER, AIIMS, PGI and NIMANS exam separately. They all have combined together to become INICET. Now before that, from 2019-18, you had twice IIMS exam, twice JIPMER exams, twice PJ Chandigarh exam and twice NIMANS exam. In all these conditions, in all these 4 into 2 exams, plus in the last 5 years of twice JIPMER, INICET exams, and all those totally 94 MCQs have been based on Gaucher's or similar disease. So we have learned them threadbare. 40 minutes that you have spent should make sure that you will get at least one question for sure in the exam. This will obviously come in your exam in the direct pattern or in a directly modified pattern. Now what you are seeing here are Gaucher's cells. These are the Gaucher's cells, and this is where you look like a crumpled tissue paper appearance here, and this is the Erlenmeyer flask deformity. And if they say there is pseudo-osteomyelitic pattern, no inflammation, but it is looking like inflammation, it is causing bone pain, all of them point towards Gaucher's disease. Are you satisfied with this? We are coming to the end of the class. In the next 10 minutes, we'll try to finish off the class. We'll wind up the class. Just tell me, are you satisfied till now? Whatever you've understood. Can I go forward? So, glucose cerebroside in the reticuloendocrine system is known for causing the hepatosplenomegaly. Infiltration into bone marrow is causing the pancytopenia. So, for anemia, what was the clinical point here? We said the patient is having chronic fatigue. Whenever you think of fatigue, think of anemia. And when will you suspect Gaucher's disease? Whenever somebody says unexplained organomegaly, easy bruising and bone pain, think of Gaucher's disease. Why easy bruising? Because of pancytopenia, the thrombocytes have also not been formed. So whenever there is an injury, if at all there is a bleeding, to control the bleeding, you need the thrombotic coagulation factors coming into picture along with platelets. But if platelets are not there, the bleeding does not stop. So because of which easy bruising happens. Okay, now try to answer this question. Identify the incorrect statement about Gaucher's disease. Enzyme replacement therapy not available is a wrong statement. Splenomegaly is massive and progressive is a true statement. Infants can present with opisthotonus and spasm is true. Absence of mental retardation is true. Remember, no MR in case of Gaucher's disease. No mental retardation in case of Gaucher's disease. Now, this is a combined information of all the sphingolipidosis put together. So, whenever you speak about lysosomal sphingolipidosis, what is the most common lysosomal storage disorder? It is Gaucher among sphingolipids. See, mucopolysaccharidosis are also because of lysosomal storage disorder only, where the lysosomes are not able to break the mucopolysaccharides down. Here we are speaking about sphingolipids. So, among lysosomal storage disorders, the sphingolipidosis, the most common one is Gaucher's. Now, absence of cherry red spot is found in case of Gaucher's and Fabry's disease. Now, cherry red spots are seen where in most of the lysosomal storage disorders of the sphingolipids, plus whenever there is retinal ischemia and when there is retinal infarction. For example, CRAO, central retinal artery occlusion, you can have cherry red spot. And where will you find absence of hepatosplenomegaly? In Gaucher's disease, you will have hepatosplenomegaly, but where will you have absence of hepatosplenomegaly? In Fabry's disease, in metachromatic leukodystrophy, in Krabbe's disease. Remember, galactocerebroside will not accumulate in the liver to cause hepatosplenomegaly. That is an important point. Metachromatic leukodystrophy happens in the brain, not in the liver. Fabry's disease is not going to cause hepatosplenomegaly. FMK. In case of FMK, you will not be having hepatosplenomegaly. Presence of corneal clouding. Corneal clouding means the cornea will be surrounded by the sphingolipids in case of Fabry's disease and GM1 gangliosidosis. Now this will give us a recombinant understanding of a Fabry's disease. Fabry's disease, there are 3 points. One is in case of Fabry's disease, think of 3 points. One is absence of cherry red spot. The second one is absence of hepatosplenomegaly, and also there is presence of corneal clouding. Now tell me, in case of mucopolysaccharidosis, where will you have no corneal clouding? Okay, now let me ask you a question. You have Hurler disease or Hurler syndrome and Hunter syndrome in carbohydrate metabolism. Among these two, which one will have no corneal clouding? Between Hurler syndrome and Hunter syndrome, which one will not have corneal clouding? Now, in the past, generally taught information is that Hunter's disease speaks about hunter. Who is a hunter? The one who hunts. The one who hunts should have proper vision to look at the prey to hunt. So if his vision is impaired, he will not be able to hunt. He can't be a hunter anymore. So if you want to call him as a hunter, his vision should be good. So corneal clouding is not there in Hunter but present in Hurler. Are you okay with this? Likewise, in case of Fabry's disease, you have corneal clouding. Now it feels like whenever I'm walking and suddenly a cloth hits my face when I'm walking or when I'm riding my bike. If a cloth comes and hits my face, I'll not be able to ride, I'll go and hit. So when a fabric comes and hits my eyes, I'll not be able to see properly. Fabry's disease, you will not be able to have Fabry's disease, you'll not be able to have proper vision. So corneal clouding can be seen. GM1 gangliosidosis also, corneal clouding can be seen. Now, presence of angiokeratoma is a property again of GM gangliosidosis and Fabry's disease. Absence of mental retardation is a property of Gaucher and Fabry's disease. The one with X-linked inheritance is Fabry's disease. So Fabry's disease, if a short note is given for you as an MBBS student, you can have at least 5 points from this one slide. Repeat: absence of corneal clouding, presence of corneal clouding, absence of cherry red spot, and you'll be having the absence of hepatosplenomegaly, and you'll be having absence of mental retardation, and it is having X-linked disorder. 5 things to write about Fabry's disease, done and dusted. Now look at this. This is how cherry red spot looks. This is the cherry red spot, and these are seen in lysosomal storage disorder, retinal ischemia, retinal infarction, central retinal artery occlusion. Apart from that, you can also have this cherry red spot in malignant hypertension because of bleeding, diabetes, radiation retinopathy, posterior uveitis, systemic inflammatory vasculopathies, and trauma. This is important for ophthalmology MCQs, so make sure you remember this very clearly. Okay. These are also the other diseases where you can get cherry red spot. Now, if the patient is Caucasian and he has cherry red spot, think of Tay-Sachs disease. If he is Canadian aborigine with cherry brown red spot, it is Sandoff disease. If he is an East Indian with a black spot, it can be Sandoff disease. These are minor, finer differentiation between each of the disease. All the 3 can speak about cherry red spot. But if it's an East Indian child with a cherry black spot, it is Sandoff. If it is cherry brown spot, it is also Sandoff in Canada. And if it's a Caucasian, it is Tay-Sachs disease. I hope you will be able to use them in your exam. Now, both triglycerides and HDL is increased in alcoholism. This is what I want you to remember. Now, we'll have just 3 more MCQs to finish, just rapidly revising. Which is true about G6PD deficiency? Can you tell me? Which is true about G6PD deficiency? autosomal dominant inheritance, does not give protection against malarial infection, presents as chronic hemolytic anemia, commonly causes neonatal jaundice. Which one is true? Okay, googly question. You don't have to have all the answers are right or all the answers are wrong. Look at this. It does not cause neonatal jaundice. Point number one, it does not cause neonatal jaundice. Neonatal jaundice happens because of simple hemolysis happening because of the fetal hemoglobin being broken down. So fetal RBCs are being replaced by adult RBCs, so that you will not be able to have proper conjugation for so much amount of this, because the liver is, see, there are two reasons why you have neonatal jaundice. For neonatal jaundice, there are two reasons. The first reason is the fetal hemoglobin containing RBCs should be destroyed and replaced by adult hemoglobin containing RBCs. So excess amount of RBCs have to be broken down. Point number one. Point number two, the liver of the neonate is not good enough or very immature enough to handle the excess amount of this to cause conjugation. So both of them put together can cause neonatal jaundice. But in G6PD deficiency, the patient can have chronic hemolytic anemia. That's a true statement. And if there's a G6PD deficiency, because the RBC's lifespan is decreased, there is a proper protection against malarial infection, especially in the Mediterranean region, in the African countries. In the African countries, yes, correct. In the African countries, in the Mediterranean region, because of decreased lifespan of RBCs, the malaria parasite will not be able to grow inside. The Plasmodium vivax will not grow inside. That is why you will not be able to have, you can actually have resistance and protection against malaria. So option B is wrong. Now, autosomal dominant inheritance, go back and check what inheritance is it. Okay. Okay, answer. Which of the following is wrongly matched? A, B, C, D. Which one is wrongly matched? Excellent, Stardust, you're correct. Vitamin B12 is known for causing neuropathy. Do you know how? Because vitamin B12 has two important forms, active forms. One is methyl B12. The other one is adenosyl B12. If adenosyl B12 is deficient, the patient may have tiredness. Can you tell me why? In adenosyl B12, the patient can have tiredness. Do you know how? Because adenosyl B12 is the coenzyme for the enzyme methylmalonyl-CoA mutase. Methylmalonyl-CoA mutase is very important for one important reaction. That is, when you have odd chain fatty acids and when you have branched chain amino acids, the end product of both of them will be propionyl-CoA. But propionyl-CoA cannot enter into TCA cycle. Only acetyl-CoA can enter into TCA cycle. Now this propionyl-CoA will undergo carboxylation to become methylmalonyl-CoA. Now this methylmalonyl-CoA will be initially D, which turns into L based on one more enzyme called as racemase. Now how did propionyl-CoA become methylmalonyl-CoA? By carboxylation. And that carboxylation requires which vitamin? It requires biotin. The first step requires biotin. Biotin is also very important for fatty acid metabolism in the form of carboxybiotin. So propionyl-CoA requires biotin to become methylmalonyl-CoA. That methylmalonyl-CoA will be converted from D to L. Now this L methylmalonyl-CoA will go for rearrangement to become succinyl-CoA, and that requires the enzyme methylmalonyl-CoA mutase, which requires adenosyl B12. For all the other methylation reactions, methyltransferase enzymes require the vitamin B12 called as methyl B12. Now that methyl B12 is important for methylation of the formation of sphingomyelin. For sphingomyelin, you require methylation. Can you tell me why? In sphingomyelin synthesis, you require methylation. Can you tell me why? Come back to this slide where you can have seamless integration. In this slide, do you remember I told you sphingomyelin is made up of ceramide plus phosphate plus choline. Choline is a methyl-rich nitrogenous compound. You will be having N here, and you'll be having methyl, methyl, methyl. Only when you're able to add methyl group to the nitrogen, only when you're able to add methyl group to the nitrogen, continuous methylation can produce choline. Only then you will be able to convert the ceramide into sphingomyelin. So for that methylation, you will require methyl B12. Sorry. Yes. Now, zinc is important for proliferation of cells, and they're important for gonadal genesis and also for beating the immune cells to be active. Now, can anybody tell me how copper causes anemia? Of course, iron deficiency does not cause xeroderma or dry skin. Can anybody tell me how copper can cause anemia? Copper deficiency, how can it cause anemia? Excess copper can also cause anemia. Copper deficiency also can cause anemia. Both of them have opposite concepts. See, when copper is in excess, it will compete. The copper in the form of Cu2 plus will compete. This is copper. Cu2 plus is cupric. It will compete with Fe2 plus to the carrying state of divalent metal transporter present in the luminal surface of the epithelial cell. The epithelial cells will contain DMT, which will carry the divalent metals into the luminal cell, into the epithelial cell. But if copper is in excess, then copper will compete with the Fe2 plus for absorption, because of which you may have anemia. So it can block the iron uptake. At the same time, copper is required for superoxide dismutase, which is important for dealing with free radicals. When free radicals are not dealt with, many kind of cells can die. Because of it, the epithelial cells, if they are dying from the GIT, when the epithelial GIT cells are dying, the rectal and the intestinal colonic cells, if they are dying, then the iron that is stored in the form of ferritin in the epithelial cells also will be sloughed off, because of which you'll have iron deficiency. At the same time, copper is important as a ferrioxidase causing enzyme. Ferrioxidase. Who is the ferrioxidase here? Copper is at the center of ceruloplasmin, which is acting as a ferrioxidase to convert Fe2 plus to Fe3 plus, which is not there, because of which you will not be able to have copper. You will not be able to have hemoglobin. At the same time, copper is important in the electron transport chain. Copper in the form of copper A, copper B is present in the form of complexes in the electron transport chain, because of which again you can have fatigue or improper formation of, yes, very good, improper formation of ATP. Iron is not related to that of this. Okay. PUFA is rich in all the following except groundnut oil. Among the following, which one is the most essential fatty acid? Is linoleic acid. What are the wrong concepts of fatty acids? Most of the naturally occurring unsaturated fatty acid exists as trans isomer is wrong. Most of the naturally occurring unsaturated fatty acids will be seen as cis isomer, and PUFA is essential for membrane structure. Why? Imagine whenever you draw a phospholipid bilayer, this is the phosphate head, and you will be having a fatty acid. This is phosphatidic acid, this is a fatty acid. If it is saturated fatty acid, you will be drawing the lines like this. Whenever you draw the lines like this, it speaks about unsaturation. Unsaturation will offer the kink. This kind of sharp twist is called as kink. And when the kinks are present on the biological membrane, lateral movement is possible. So you will be having enough amount of elasticity in the blood vessel wall or in the cell's membrane. So cell membrane will be more supple and more elastic. But if you are filling the areas with saturated fatty acid, you will not be able to have proper cushioning effect in the cell membrane. That is why the cells become hardened. So atherosclerosis can happen because of this. So have a look at this. The high amount of medium chain fatty acids and short chain fatty acids are present in palm kernel, coconut oil, butter. And high amounts of monounsaturated fatty acid and moderate linoleic acid are present in groundnut oil and rice bran oil. Highest content of each type of fatty acids. For example, flaxseed oil is containing highest amount of alpha-linolenic acid, MUFA in mustard or rapeseed oil, MCFA in coconut oil, linoleic acid in safflower oil. Repeat this. Now, this is the last question for the night. Tell me if you can answer this. Tell me if you can answer this. all the following can be components of the lipids called as gangliosides, except which one is not a property of gangliosides? Which one is not found in gangliosides? Excellent, Prem Kumar. Glycerol is not present in ganglioside. Glucose is present. NSL galactosamine is present. Sialic acid is present as NANA. Now tell me, if I add 3 sialic acid residues to the ganglioside, how will I name them as? If I add 3 sialic acids, how will I name them as? If I have 3 sialic acid residues in the ganglioside, how will I name them as? GM means 1, GD means 2, and GT means 3. 3 sialic acid residues. Okay, before you go home, just have a look at this and tell me if you can find out what case is this. Very good, Zainab, Stardust, Prem Kumar, Sarvana Krishna, Abhishek and Krishna Priya. Very good. See, an enzyme transfers phosphate to carbohydrate residues on specific proteins so that they serve as a marker for proteins to be targeted to the lysosomes within the cell. Without this marker, proteins are instead secreted outside the cell, which is the default pathway for proteins moving through the Golgi apparatus. This leads to the condition characterized by the picture given here. Now, who is the carbohydrate involved in this whole problem? You don't have to answer, just read the question once again. You don't have to answer, just read the question once again. An enzyme transfers phosphate. So the enzyme is a phosphotransferase. Now this phosphotransferase should happen onto the carbohydrate residues on specific proteins so that they serve as a marker for proteins. Saravana Krishnan, very good. The answer is mannose. Very good. Now remember, what are the things you have to know? When a protein is synthesized, this should be added to phosphate, where a mannose residue should be bound to protein so that that mannose will go for phosphorylation to become mannose 6-phosphate. A freshly formed protein will have a tag called as mannose, which is bound to a phosphate. So that mannose will act as a marker and it will take the protein, if it is done, if the lifespan of the protein is done, it will be taken to the lysosome for breakdown. When the enzyme, the phosphotransferase is not present, the mannose will not become phosphorylated. If the mannose does not become phosphorylated, it will not be able to direct the protein into the lysosome. Or if mannose itself is not there, it can't go to the lysosome. So the carbohydrate involved is mannose, and the mannose 6-phosphate is not formed. So targeting of the protein to lysosome is not happening, and then this particular compound of the protein will start accumulating inside the cell because of improper activity of lysosome. This is capable of causing an inclusion body, and those cells will be referred to as inclusion cells, and this disease is referred to as inclusion cell disease or eye cell disease. This is referred to as inclusion cell disease or eye cell disease. Tay-Sachs involves increase in accumulation of GM2 gangliosides. In human and fungal plasma membrane, which of the following is absent? In the human and fungal plasma membrane, triglycerides are absent. Remember, in human and fungal plasma membrane, triglycerides are absent, lecithin is present, cholesterol is present, carbohydrate is present. This is important for answering microbiology questions, pharmacology questions. For example, ergosterol inhibition, you can ask for in case of pharmacology, and when you like to learn about mycology, you should know that triglycerides are not present in the fungi and the fungal plasma membrane. So now, I think it has been great talking to you all. See students, for those who have been following this, in the channel that you are watching, please click on the subscribe to this channel so that you will be able to see notifications for the upcoming class. Till the next 15 days, Manipal Med days, faculty. Each and every faculty, for every one single subject, one day will be allotted. You can come for the subsequent classes. Now tomorrow the class is microbiology class, again done by me. For those people who are preparing for entrance exams, I'll try to discuss very important INICET questions and concepts. If you come back, I'll be very happy to teach you some new concepts in microbiology, and old concepts will be revised. You can bring all your doubts and clarifications to be had. I'll be very happy to answer all your questions. So tomorrow at 6 p.m. If more people are there, we'll discuss it for long. If less people are there, we'll discuss it for a short period, completely dependent on you. If you can come for the class, I'll teach you a lot, as much as possible within the given span of time. So for all the people who have been very patient in the last 2 hours to listen to me, thank you very much. All the very best for your preparations, be it your undergraduate classes or for your INICET preparation. All the very best. And those people who are watching it, you can actually subscribe to my Instagram page. It is Bio and Micro by DRASM. Micro, Bio and Micro by DRASM, where I'll post regular updates about all the classes. And thank you very much for all of you for being very patient here. Have a good night. For those who are willing to come tomorrow, I'll see you tomorrow. Tomorrow, half an hour earlier at 6 p.m. Bye. Good night. Thank you, Saranakrishnan. Thank you, Stardust. Thank you, Mukundan. Thank you, Human Nature. Thank you, Sutish. Thank you, Prem Kumar. Thank you, Chito Dust. All of you have been very kind. Thanks a lot.